Yeah. We can get started. It's 3:31. I suspect people will probably trickle in as they're wrapping up their coffees and water breaks. Bio breaks is what somebody calls these breaks. Isn't that nice? Yeah. So I will go ahead and introduce our next speaker, who I personally requested to introduce myself. It's not coincidence. So Whitney Maikkula is a registered student nurse midwife, and a priest's wife who lives on the south side of Chicago with her husband, Father Philip, and 3 children, who I have the great privilege of knowing because this is the parish that I go to, and we're very good friends with this lovely family. She has been a nurse in multiple emergency departments in 4 different states over the last 11 years, and will be graduating with her Master of Science in Nurse Midwifery from Frontier Nursing University next summer, which I'm very grateful for because last year I gave birth to my first daughter, and I had been talking to Matushka Whitney while I was having contractions, so I'm very thankful for her. In addition to her studies and work, she homeschools her children with the help of her husband. Whitney enjoys taking long road trips, hiking with her family, and playing board games in whatever spare time she can find. Her husband, Father Philip, is the priest at their church, St. Macarius Orthodox Mission in Hyde Park on the south side of Chicago, where they have lived since August 2020. Welcome.
Thank you, Susan. I figured that wasn't coincidence.
Do you want us to move up a little bit? Would that be helpful?
No, I don't really care because I'm a back of the classroom person, so I would not want to push that on anybody else if they don't want to. Welcome and thank you for coming to my workshop, Responding to Health Disparities with Christian Love, an application of the Ascetic practices of St. Maria of Paris in the modern healthcare setting. And I think that's the longest title of the whole conference, so pretty proud of that. This is a picture of me and my family last Pascha. I have Ira, who's 9, Zephaniah, who's 7, and Lucia Marie, who is 3. And her patron saint is Saint Maria. So me and my husband are a little bit obsessed, but we couldn't have a Maria Maikkula, Mary Maikkula. We're not into the alliteration. So I'll tell you a bit about myself, aside of what Susan just said. I grew up in South Florida. Got my Bachelor of Science in Nursing at the University of Central Florida. A couple years after that, we moved to New York so my husband can go to St. Vladimir's Theological Seminary. He graduated from there in 2018. We went down to Greenville, South Carolina, spent 2 years there. And at that time, we weren't sure if Father was going to go into ministry or do not-for-profit work. It was just kind of like a limbo. What are we going to do? And then 2020 was 2020. And soon after the pandemic hit, we just got a random email about this opportunity in Chicago. And here we are. We moved August 2020 to live on the south side at what was then the only Orthodox parish on the south side of Chicago. But now I think there might be another one like on the west side. Anyway, like Susan said, I've been a nurse for 11 years in the emergency department, and I've had this long-standing passion for maternal health care since having my own kids, and especially after having numbers 2 and 3 with midwives who basically changed my life. They're wonderful people, and when I experienced my births with the midwives, it was just kind of like, oh, there's actual medical providers out there that see you as a person and don't rush through your appointment and actually don't mind speaking to you. This is revolutionary. I didn't know they existed. So I had it in the back of my mind, maybe I'll go into midwifery eventually, not when my kids are young. We moved to Chicago, maybe I'll have another baby eventually. Let's see what the maternal health care looks like on the south side. It's terrible, okay? What I started learning about, and we're going to go through some statistics so you can see. I was like, this is horrible. There's a great need to be filled. And let me see if I can fill it. So I just, on a whim, applied to midwifery school. And I'm done with my didactic courses, thank God. And I just have clinical to do. So please pray for me over the next year because it's, I'm almost there, but I'm also so far. The objectives for this workshop are that the attendee will be able to define and give examples of health disparities, explain why it's essential for Orthodox Christians to address health disparities in their communities, understand basic concepts of St. Maria's mysticism of human communion, which is a lot of big words, but we're going to go through it, and provide 2 to 3 practical examples of actions and ways that we can approach our work in the healthcare and psychiatric environments to apply her theology. So, what are health disparities? Does anybody know next to nothing or somewhat about what a health disparity is? Are we familiar? Not familiar? I mean, it's kind of a buzzword. It's kind of like a big, more like governmental thing, right? We have all these health disparities that we need to fix. The CDC defines it as preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. And then there's this concept of equity, which is kind of the opposite of a health disparity, that the World Health Organization defines as the absence of unfair, avoidable, or remediable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically, or by other dimensions of inequality, such as sex, gender, ethnicity, disability, or sexual orientation. The World Health Organization continues on in that same document to state, health is a fundamental human right, and health equity is achieved when everyone can attain their full potential for health and well-being. So health disparities are a result of inequitable healthcare, which unfortunately in our country is super prevalent. And we're going to go through some examples. Oh, and I thought I had 2 links up here, but that's okay. Okay, so the first example is, and this is all going to be from maternal health, so I'm sorry if that's not your thing, but that's what I know. So we're going to talk about maternal and infant health. So the first one is maternal mortality rate, which is defined as the death of a woman while pregnant or within 42 days, which is 6 weeks of termination of pregnancy, irrespective of the duration or the site of the pregnancy, from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. And maternal mortality rate is a huge health metric that they measure nationally and by state, and it is reflective of a country or state's healthcare system because many maternal mortality cases are preventable. It's usually sepsis in the postpartum period, hemorrhage, or related to blood clots. So nationally, the overall maternal mortality rate in 2021, it was 32.9 per 100,000. And all this is going to be for the maternal mortality per 100,000. That's a terrible number. It's up from the 2018 rate in America, which was 17.4. So pre-pandemic, 17.4 per 100,000 to post-pandemic 32.9. So that includes all the terribleness that was 2020 and 2021. Lord willing, we will see it come down in these more recent years. To put that in perspective, Healthy People 2030 has set a goal for the United States maternal mortality rate of 15.7. So they want us to cut it in half. But before it was 17.4, so that's pretty close. And then in Chicago, they measured this maternity-associated mortality, which is a lot more expansive. And it is defined as the death of the mother occurring during pregnancy or up to a whole year after the end of pregnancy, regardless of the cause of death. So yes, this does include accidental causes that have nothing to do with the pregnancy, but it also includes a lot of deaths that are not included in the maternal mortality rate, postpartum suicides, domestic violence deaths, and longer-term health consequences. So it's a lot more inclusive. So the numbers are going to be a little bit different, and we really shouldn't be comparing the two. But I just wanted to point this out. In Chicago, the maternity-associated mortality rate for non-Hispanic Black women is between 2011 and 2016 was 98.8 per 100,000. For non-Hispanic white women in Chicago, it was only 17 per 100,000. So that is 5.8 times higher risk of dying during pregnancy or the year after pregnancy if you're a Black woman in Chicago compared to a white woman in Chicago. That should not happen, right? And this is also seen when you control for income and education. So And a lot of research has kind of concluded that it's more dangerous to give birth as a well-educated, wealthy Black woman than, more dangerous than a poor, uneducated white woman, which just floored me when I heard these statistics. Okay, 2 more things we're going to look at. Oh, good, it came up. Actually, let's go to that now. I love a good interactive map. Okay. This kind of gives it away. Mississippi has the highest maternal mortality rate of 2021. We're going to scroll down and to our interactive map and see that it was 82.5. Here in Illinois, about medium, 31. Where is everybody else from? We have Georgia. Ooh, it's mirrored. Hold on. 49.2. Okay, anybody else?
Colorado.
You guys are good. 17.5. California has the best, so let's see how that compares to California. 9.7. Yikes, they're good. Anybody else?
It's not all areas of California or all populations within California. Let me say that out loud.
Oh, I didn't hear what you said, but I believe it. Anybody else from, I know there's somebody from Greenville, 43.7. And then I don't know, so Mississippi's 82.5, New Mexico's 79.5.
What is Alabama? That's the one next.
Let's see. 56.8. So I just think that's interesting. I love comparing geographic things like that.
Are the gray states no data? Or
I guess so. I don't know why they're gray. And then MMR by country, which is also fascinating.
Could be inadequate denominator, just not much population.
Now this data is from 2000 to 2020, so it's kind of old. Obviously, third world countries, countries with hospitals with poor resources are going to have not great rates. But blue, hold on, there you go. Blue is very low, which is below 100, and this is per 100,000. So most of the world's very low, but that there's a big range there, right?
Yeah.
So in America, for this set of data, it was 21 per 100,000, compared to Canada with 11. Russia, 14. Does anybody have a country they want me to cover over? Egypt, I think they were higher than us. Oh, 17, lower than us.
That's surprisingly low.
I know. I mean, I don't know how the data was collected, and it was over 20 years, but this is from UNICEF. So anyway, it's just interesting. I don't know if everybody's aware that our maternal mortality rate in America is
Europe or
less than good. Okay, so Sweden's always really good, 5. Norway, 2. 10 for United Kingdom, Spain.
And what was the U.S. again?
21.
21.
Oh.
There's a lot that goes into it. That could be a whole 3-hour lecture. We're not going to get into that, but it's just putting this into perspective. What were you going to say, Susan? What were you going to say?
Egypt,
You want to look into India?
That just goes, them 17.
Yeah.
Like, there's no data collection.
I'm curious about South America, some of those dark blue.
Yeah.
Brazil. So it's weird because it's low, but it's also 3 times higher than us.
It seems like very low is considered anything below 100.
Yeah, it's a huge range, but they have to compare it to some that have.
Oh, it's above 1,000.
Yeah.
I see.
So that would be countries, Nigeria.
It's like 1%.
I'd love to see the dark blues get stratified into 2 different, like below 50 and above 50. Instead of just
Well,
right?
we're going to play Jeopardy in a little bit.
Okay.
And we have a question that will at least shed light on where America ranks.
And the other thing I'd love to see is the reliability of
Each
country's data.
Yeah.
Where it's like,
I mean,
here's the number, like Norway.
What's the
low
reality?
Number with a high rate of confidence. United States, relatively high number, but with a high rate of confidence. And then there's other countries that's like, yeah, man, that's a low number, but the confidence level that this number is real.
Yeah, I didn't have time to do that much digging.
No. Neither did they.
Right.
The data doesn't exist. You didn't find this that bad. Really.
Yeah.
We just don't want to believe it.
Yeah.
So then we can look at infant mortality rate, which is another big reflective of what the healthcare system in a country is like. This is defined as death within the first year of life. In 2019, nationally, the preterm birth rate for non-Hispanic Black babies was 14.4%, non-Hispanic white babies 9.4%. And if I only mention those 2, usually Hispanic Latinos, Native, Alaskan, Hawaiian is usually kind of in between. And then Hispanic Latinos is 5.3%. And then lastly, preterm births, which is a big cause of long-term disability, financial and other strain on families. Nationally for 2021, non-Hispanic Black rate 14.8, and then non-Hispanic white rate, I don't know what that says, 9.5. I added some things there. So that's the picture of, at least with maternal health. Oh no. Okay, here we go. So why do health disparities exist? This could be another 5-hour presentation, but we're going to try to be a little succinct, and I'll probably miss some whys. The CDC lists, very simply, some very obvious ones, right? Poverty, environmental threats, so that could be like your family life, domestic violence, poor air quality, poor water quality, inadequate access to healthcare. And I found this, I knew that labor and deliveries were closing in Chicago in general, but I read in a recent news article that says before 2019, there were 19 hospitals with birthing units. That's labor and delivery unit hospitals with labor and deliveries, right? 6 on the south side. What would that be? 13 on the north side. Post-pandemic in 2021, there are now 6 on the north side, which, if anybody doesn't know, that's the more affluent side. It's typically the more affluent side of Chicago. And on the south side, which has lots of people, only 3 hospitals with labor and deliveries, which is obviously inadequate. Individual and behavioral factors, there's things like drinking, smoking, sedentary lifestyle, poor diet, and then educational inequalities, which goes along with not great neighborhoods. And this is a map that I really like. This is Chicago by zip code. So you have the light ones with all the crunched up zip codes up there. That's downtown. I wish I had a pointer. This little dark blue one is where Michelle Obama grew up. The one diagonal to that is where I live. The light blue one above that is where our church is. And then O'Hare is off way up to the northwest. It barely counts. So this is comparing the light blue to dark blue as severe maternal morbidity. Another statistic definition. It is when a woman experiences one of a list of diagnoses that leads to short-term or long-term disability during pregnancy or after. So sepsis, blood clots, heart attack, eclampsia, stroke, hysterectomy, amniotic fluid embolism. It's like the big bad things that happen to pregnant people and postpartum people. The higher rates are the darker blues, and then the diagonal shading is high economic hardship. I don't know how they measure that, but clearly there's a correlation between high economic hardship and poorer health outcomes. And I just like when maps are simple and show stuff like that. Okay, so why do health disparities exist, aside from what the CDC says? There's this concept of allostatic load, defined in this Guidi et al. Study as the cost of chronic exposure to fluctuating or heightened neural and neuroendocrine responses resulting from repeated or chronic environmental changes that an individual reacts to as being particularly stressful. So this is like chronic stress, acute stress on top of chronic stress, and what it does to our bodies. Contributing factors, we all get stressed out with these things: birth, death, divorce, major relocations. Behaviors contribute to the stress load on our body: poor sleep and the resulting circadian dysrhythmias, lack of exercise, smoking, all those unhealthy habits. Environmental stressors, like we discussed before, the unclean water, unclean air. And the study showed, along with other studies, that low socioeconomic status is associated with high allostatic load. I think that's pretty obvious, but we also don't kind of think about the single moms with 5 kids who work full-time and are living paycheck to paycheck, which is all over my neighborhood and super prevalent on the south side of Chicago. So, and then discrimination based on race, weight, gender, and other things. So what happens whenever somebody experiences this chronic stress and then acute stress is on top of this chronic stress? Our body is in a continuous sympathetic nervous system overload, fight or flight always. Our amygdala is in charge and actually will grow in mass if we are continually stressed. Immunosuppression will result from that. Altered blood glucose levels, high cholesterol, blood pressure, increased systemic inflammatory markers, increased BMI, stress eating, or other eating disorders, and then increased risk for cardiovascular problems, poor pregnancy outcomes. High stress often leads to preterm birth and other pregnancy complications later in pregnancy. And I did see specifically breast and ovarian cancer, and I am confident that other cancers are caused from this too. But those are the two I specifically saw in this article. And then there's this concept of implicit bias, which the American Psychological Association defines as a negative attitude of which one is not consciously aware against a specific social group. This can be shaped by our own personal experiences, and it can affect our perceptions and behaviors towards other people. They say that we all have it. And there's this very interesting implicit bias test that Harvard has. You don't have to write that down. If you just type in Google Harvard implicit bias test, it's the first thing that comes up. And it's not like how much do you know about this multiple choice. It is a like sorting thing. So you sort these pictures and it tests your time. And I only did one of them just to see what it was like. But it was very interesting, and it did show that I have some implicit bias. But we all do because of where we come from and our environment. The key is just being aware of it and knowing that it can potentially affect our behaviors towards others. Okay, and this is more anecdotal. There's not a ton of like huge research studies that show numbers for this, right? But I hear people in my life, especially people of color, saying, I said this to my doctor and they disregarded me. I'm not heard, I'm not noticed, and then this bad thing happened.
There is data on this, by the way, specifically around pain.
Yes, I have a Johnson study that I'm gonna.
Labor pain, you know.
Yeah, there's a like post-cesarean pain thing, which I have an example of here actually.
Sorry.
Wait, I missed these. I have missed a whole little thing on implicit bias. So there is a study by Johnson et al. They did in 2019, entitled "Racial and Ethnic Inequities in Postpartum Pain Evaluation and Management." I'm glad you said that. This study looked at racial and ethnic disparities in post-C-section pain assessment and management, and it showed that Black and Hispanic patients had greater reports of severe pain than white or Asian patients. However, Black, Asian, and Hispanic patients had fewer pain assessments in the 48 hours post-op than did non-Hispanic white patients. So they were being asked by the nurse, what is your pain level? The non-Hispanic white patients were being asked that more often than the minority patients, even though the minority patients were having ratings of higher rates of severe pain. And in addition to this, they found that Black, Hispanic, and Asian patients received less narcotics for pain relief during the first 48 hours post-op compared to non-Hispanic white patients. So these minority patients were saying, I have a lot of pain, and these patients who are saying, I have moderate pain or whatever, are getting better pain medications. And we all know narcotics are a problem, but 48 hours after my stomach being cut open, please give me like one at least, right? So, again, thank you for saying that. So back to this patients feeling unheard. Pain management is a big problem with that. But also, I watched this documentary recently. It's on Hulu. It's entitled Aftershock. It follows the significant others of these two women, Shamani Gibson and Amber Rose Isaac, who, and I think this occurred like during the end of 2020, beginning of 2021, one of them had a baby and was reaching out to her healthcare provider saying, I'm having these symptoms, I can't breathe, I'm really, really tired, my chest hurts, and was just brushed off. And you're just a new mom, of course you're tired, yada, yada, yada. She ended up dying, I believe, of a pulmonary embolism, just because she was disregarded and they didn't have her come in. And I say that it happened in 2020 to 2021 in New York City, which, Lord have mercy. Maybe her providers would have seen her if they weren't in the middle of a pandemic, but regardless, it was preventable. And this other woman, her platelets went from like normal range, like all the way down to like 10, and nobody really like followed up on it or noticed or treated it or did anything. And there's a couple more details to that story, but she ended up dying in an emergency C-section. Preventable if we had just noticed, right? Or if our providers had just listened to the patients, because obviously these are tragic stories, but they're not super unique. So I think we're ready for Jeopardy. You guys can stop listening to me talk. I have no way of picking, hold on, let me get my mouse. I have no way of picking who is gonna ask questions, so you guys can just randomly say, I'll take this for blank 100. And it is mostly a recap of the stuff we went over, but there's a couple questions that we didn't go over that you have to make an educated guess on. Okay, who wants to answer the first question? Or who wants to raise their hand and volunteer to go first?
Chicago for 100.
Chicago for 100. The number of these in Chicago decreased from 19 to 9 from 2019 to present.
Is it?
It's not for close.
Birth centers.
Close. Birthing hospitals.
Birthing hospitals.
Labor and delivery unions.
What is labor and delivery?
There you go. You know, I put it up here to pressure you guys. Oh no! To pressure you guys to pressure you guys to say it correctly. All right, let me see if I can get these buttons correct. Oh, come on. Okay, well, who wants to do this one? The higher rates of severe maternal morbidity are often found in zip codes with high blank blank.
What is socioeconomic?
What did they say? Economic hardship. You were saying the correct thing. All right, but it's supposed to take me back to the Jeopardy board. What is economic hardship? Let's see if it'll do it this time. Okay, yay. I did not make this Jeopardy thing, but I'm really glad I found a template for it. All right, who wants to go next?
Definitions for 4.
The death of an infant before his or her first birthday.
Infant mortality.
Yeah, you got an easy one.
What is?
Yeah, come on, you get it wrong if you don't say it correct, okay? All right. I think there's 2 in here that are hidden that are, you don't actually know yet, but you can make a good guess. All right, anybody else?
Okay, what is contributing factors for 300? You're right over it. Where else to go?
A subconscious negative attitude towards a specific social group.
What is implicit bias?
Yeah. Was that 300? I'm crossing out the ones we did because they're not shaded. All right. Who's next?
Chicago for 500.
The number of birth centers in the greater Chicago area. I should have said freestanding birth centers. Do we know what that is? It is an outside of the hospital, freestanding center where certified nurse midwives can deliver babies. And they still have medical equipment, but it's for like low risk women, but it's not attached to a hospital.
What is? I have no idea.
2,
Ooh,
which is also terrible.
where are they?
Southwest suburb and then downtown.
And those are for low risk? Or
Yeah, it's for, keep this in mind, like 90% of women are low risk. So, yeah, it's low risk, not gestational diabetes, not any hypertensive disorders. Some of them have an age limit. But yeah, basically a patient with no complications who's ready to give birth.
I'm curious about an average number. Is 2 considered low in Chicago relative to the rest of other major cities and states?
It depends. Chicago had really restrictive birth center legislation that recently was overturned. So they're working on establishing new ones. But in Florida, there's 20 or 30. So, and in the state of Illinois, there's 3 now.
Wow.
So, and they are great for good outcomes. When a low, when an uncomplicated young woman goes into labor at the hospital, their risk of complications go up significantly. All right. Does anybody else want? We don't have to do all these, but
what
does
is
anybody
United
else?
States, or no, United States for the 100?
For 300?
Yeah.
In 2021, this rate was 32.9 per 100,000.
Maternal mortality rate?
Yep. Ding, ding, ding.
Wow, that's high.
Well,
Yeah. Versus the 17.4, I think, in 2019.
unbelievable.
Oh, I guess we're going to the next one. Yeah, it is unbelievable. This state has the lowest maternal mortality rate.
California.
California. I don't know why I just went to the next one. All right, does anybody else want to do any more? Otherwise, we can continue.
Can I ask? Go ahead.
Go ahead.
Could I ask, if this is not a joke, but maybe you have it hidden in there. What's your practice guideline protocol for midwives in the state of, in your state?
In Illinois, until you get your independent practice license, which is like working 3,000 or 5,000 hours or something like that, like those first 3,000 or 5,000 hours, whatever it is, has to be either in a hospital or directly under a physician. So like in a physician's office, you're like the midwife at that office. After that, you can apply to the state to get independent practice authority, which allows you to work completely independently of a physician. So they kind of just want like the new nurse midwives to practice under some supervision, basically.
And then do you do a collaborative agreement?
Nope, we don't.
You don't have to.
Mm-mm. I think possibly birth centers may need to. You know what? Okay, this is taking me back to like first year of midwifery school. I think you may have to for like out of hospital births. So freestanding birth center or home births. I think you need to have a collaborating physician. But if you're a midwife practice, so there's no physicians involved and it's just 5 midwives who deliver babies, you don't have to have a physician involved if you're delivering at a hospital. Mostly because there's going to be a OB on call anyway that you can call if an emergency happens. So
Collaborating practice, just nurse practitioners in some states have a collaborating physician that they can call if something comes up. Or in my state of Georgia, I can write OxyContin, but I can't write Ritalin. So they write my prescriptions for me. Weird.
yeah, some of them are more restrictive than others.
I have a question
Yes.
about this rise, and I guess I've been out of it, and I didn't realize that happened in the U.S. But it oddly correlates with the time when prenatal care standards became changed. Like instead, it's kind of instead of 4 weeks, it's 6 weeks, and a lot of virtual care.
Mm-hmm.
And did in any of your research on this, was that a correlation, or was more just women weren't showing up for prenatal care because they were scared and stayed at home, or what? Like,
Yeah.
do you have a sense of what some of those underlying factors? Because all the racism, social hardship, all that stuff, economics. I mean, economics maybe have gotten a little bit worse, but that existed.
That's been around, right?
Yeah,
Yes, that's
been
like
around.
long-standing, unfortunately. I don't know if anybody's gotten down to like the why that has happened
Yeah.
between 2019 and 2021. I'm sure somebody's delving into it, but as far as I know, most practices, at least in academia, are that whole like doing 6 weeks instead of 4 weeks or doing like a virtual appointment was just like a pandemic thing. I don't know if practitioners are still doing that. So I don't know if they know the why yet, or if it was just COVID affected. It did affect.
Pandemic numbers. Those are pandemic numbers, right? Those are 2022.
That was the 2021 rate. So
Yes.
yeah. So definitely still in the throes of the pandemic. So I'm gonna move on to our beloved Saint Maria.
Thank you. Sorry for.
No, I like the interaction because then I don't have to drone on. Oh, well, I did link it, I guess.
Saint Maria, Jeopardy.
Oh, okay. So not quite Saint Maria yet, but what can we do about this? Obviously, this is a like systems level problem. I can't fix these neighborhoods in my state. I can't fix the schools in my state. I can only very limitedly educate my patients on healthy behaviors, but there's not a whole lot I can do, right? The American College of Obstetricians and Gynecologists encourages providers to acknowledge that race, institutionalized racism, and other forms of discrimination serve as social determinants of health. That might be more scandalous to some people than others, but even just acknowledging that is a factor, especially if you serve a lot of minority patients. Most of the patients that I see in the south suburb that I work at are Black patients. So it helps me to keep fresh on this stuff. And before midwifery school, I didn't know any of this about health disparities, and it really scandalized me in a good way. Address our own implicit biases by kind of just being reflective on our how our upbringing may have affected how we see people. And I felt that acutely when we moved to the south side of Chicago. I've always lived in very white areas, and I would go to the grocery store and be the only white person there. And I was like, okay, I need to acknowledge that I feel uncomfortable. Why do I feel uncomfortable right now? And this is how Black people in all the suburban places I've ever lived feel. And then ideally we could have the time to partake in political action, right? I don't have time for that. I have 3 little kids, maybe when I'm older. So is there something we can contribute as Orthodox Christians that is different than what these organizations are telling us we can do? Let me catch up to where my notes are real quick. So I'm going to quickly go over the life of Saint Maria. Who is familiar with her?
Is she the World War II?
Yes, Saint Maria of Paris, yeah.
Yeah, I know.
I read her bio multiple years ago, and I had to refresh myself on a lot of her stuff for this. And I always appreciate a refresher on saints' lives. So let me refresh you. She was born in 1891 by the name Elizaveta Pilenko, southwestern Russia, along the coast of the Black Sea near a town called Anapa. Grew up in an Orthodox family, but then declared she's an atheist after her father's death at the age of 14, a sudden, unexpected death. She felt it was an injustice, and God would not do that. So therefore, God does not exist. She moved to St. Petersburg in her late teens as an adult, was married to her first husband. Try not to be scandalized by the word first. There she ran with like the intellectuals and the poets, and she became a published poet at that time. And then she also found herself kind of irresistibly drawn back to the church, more on an intellectual basis, and then it went into practice for her. I'm getting ahead of myself. And then she even studied theology at the Theological Academy of the Alexander Nevsky Monastery, which was a school that at the time trained priests, and she was the first female student. So nobody really knows why they admitted her, because it wasn't like they were trying to start getting females to come. She just applied and they allowed her. So when the Russian Revolution happened, she returned home. And her first daughter, Guyana, was born in 1913. The same year she became estranged from her husband. Thus the return home to where mom is. During the revolution, she became mayor of her town. I didn't know that before refreshing myself on her story. Fell in love with, she got arrested for something political, and then the judge who was on her case, judged that this was silly and go home. And then they got married. They fell in love and got married. She became pregnant with their son, Yura, and they fled Russia in 1920 because they just deemed it was not safe for them anymore. Yura was born in Tbilisi later on in 1920. A year later, they left for Istanbul, and then to Yugoslavia, where her third child, Anastasia, or Nastia, was born. And that was in 1923. Shortly after Nastia was born, they settled in Paris, and that's where they stayed. So they got to Paris in 1923. This is a picture of her and her kids. Baby Nastia, still very fresh there. And then Nastia died of meningitis at the age of 3 in 1926. And clearly, that was a terrible moment in St. Maria's life. But it was a turning point as well. She became, in her grief, she found herself, quote, "I'm aware of a new and special, broad and all-embracing motherhood." And Jim Forrest describes it as, she found a new road before her, a new meaning to life, to be a mother for all, and all who need maternal care, assistance, or protection. So her 2 older kids are a little bit older now. After the burial of Nastia, she just had this overwhelming sense of this broad motherhood for people struggling. Shortly after Nastia's death, her and her husband separated. After they separated, she kind of devoted herself to social work. She would also give intellectual talks throughout France. She would just kind of do random things like go to a factory of some sort to give a talk on Dostoevsky or something. And when she tried doing that, the workers laughed at her and they're like, we don't need to talk on Dostoevsky. We need like help with our laundry and our life is terrible here. So she rolled up her sleeves and like went and like cleaned their apartments and stuff like that. And then after she like met their physical needs, they were like, oh, well, now let's talk about Dostoevsky. Let's, So her social work included housing the unhoused, feeding the hungry, helping Russian immigrants in mental institutions. She actually got a handful of Russian immigrants out of mental institutions because she worked as a translator and helped the therapists and staff there realize that like they're not crazy. They're just saying this thing in Russian that you don't understand. And then she would take those people who had nothing outside of this mental institution and say, come work at my hospitality house. So she had a couple physical locations for hospitality where she would house the unhoused and feed the hungry. And she really just like put all of herself into this work to the point where she gave away her room. She slept under the stairs and basically gave those in need every part of her, physical, spiritual, and intellectually. In 1932, at the encouragement of her bishop and her father confessor, she agreed to become a nun. They first had to get an ecclesiastical divorce with her husband, Daniel. And it's kind of funny because the bishop went to Daniel's house and was like, convinced him, like, listen, Mary wants to be a nun, or, Elisabetta wants to become a nun, and we're all behind it. Can you just, like, be okay with this? And so then he's like, all right, fine, I consent. Which is just really funny that bishop was arguing for a divorce like that. She agreed to become a nun on the condition that she be allowed to practice monasticism in the world, is what she called it, rather than the typical life of a nun at a monastery, because that life did not sit well with her. And we'll kind of go into that in her essay that we're going to discuss. Shortly after becoming a nun, she opened that hospitality house that we just talked about, and then World War II started, Nazi occupation. I kind of give a spoiler here. During the Nazi occupation of France, her and Father Dmitry Klepinin, who was working with her at the time, and her son Yuri, were all together helping anybody who came to them with any sort of need. And it included forging baptismal certificates and church membership certificates, which they didn't think twice about. They're like, yeah, this is lying and this is forgery, but also we're saving these people's lives. So yes, we can totally do this. Somehow they were able to fly under the radar for a couple years. And then they were found out, and all of them were arrested in 1943. Following her arrest, she was sent to Ravensbrück concentration camp in Germany. And her fellow prisoners spoke very highly of her afterwards, that she gave them a family when they had no family, and that she just exuded this joy that they did not see anywhere else in the camp. And she would even, at the end of the day, she continued to hold these like intellectual talks to kind of give people, and herself, I'm sure, something to look forward to at the end of the day, but also to not give up their personhood and just be these fearful workers that the Nazis wanted them to be. Eventually, she was sent to the gas chamber in 1945. It said that the sounds of gunfire was heard in the distance from the Russian Red Army, and that's how close they were. So the Nazis were trying to like get a ton of people into the chambers to kind of like cover up the atrocities. They were picking people at random at that point. There are some accounts of witnesses that say she was randomly chosen, and then a handful of accounts that say that she took the place of a very frantic person who was chosen and willingly died that way. And it was on Good Friday. So, pretty amazing story. She wrote multiple essays, and they kind of have some interwoven themes in them, but we're just going to look at this one, the mysticism of human communion. And we're going to try to do this quickly. So her social work that we just discussed was based on the recognition of the dignity of man created in the image and likeness of God. Orthodox Action was like the organization that encompassed all of her work. The guiding principle was man in God's image. Man is God's image and likeness, the temple of the Holy Spirit, the incorruptible icon of God. Based on Genesis, let us make mankind in our image. 1 Corinthians, or do you not know that your body is a temple of the Holy Spirit, whom you have from God? And 2 Corinthians, but we all, looking as in a mirror at the glory of the Lord, are being transformed into the same image from glory to glory, just as from the Lord, the Spirit. So this formed a huge part of her theology, is humans as icons. She goes on to describe it in kind of describing, just as the priest senses the icons of Christ, the Theotokos, the saints, and then goes on and senses people. And mind you, it's not just Orthodox Christians the priest is sensing, it's anybody who comes in the church, right? Because we are made in Christ's image, in the image of the Trinity, we are worthy of veneration. Obviously not from anything we've ever done, right? But we go out to the world remaining that image of God, worthy of sensing and veneration. And she said our relations with people should be an authentic and profound veneration, which I've never, we hear of the parable of the Last Judgment, and yes, we're all made in the image of God, but do we take it that step further to venerate people? That's kind of a little extreme in a good way. I love this picture of her because it shows her ratty clothes and shoes that she wore and her cigarettes that she smoked. She's great. So this is a quote that is just doesn't need any explanation. Each man is indeed the image of God, the image of Christ, the icon of Christ, who, after that, can differentiate the worldly from the heavenly in the human soul. Who can tell where the image of God ends and the heaviness of human flesh begins? In communing with the world in the person of each individual human being, we know that we are communing with the image of God. And contemplating that image, we touch the archetype. We commune with God. And communion with man, in this sense, is simply another form of communion with God. So she argues in this essay that we're not just supposed to have this church-going self, this pious self. We do all these prostrations every day, the Jesus prayer, etc., etc. And then this separate portion of our lives that goes out into the world. And here she kind of differentiates primary and secondary, right? Primary is going to church. We have our personal monasteries with high walls where we pray, and we're very comfortable because we're with our church family. And then the secondary Christianity, where like sometimes we'll condescend to go out into the world, maybe like one weekend every 3 months, and go to the soup kitchen and help out with that. And she argues that there should not be this dichotomy, that going out into the world should be as essential as the primary Christianity, as going to church, as worshiping in your home, praying, prostrations. They should be equally essential to our Christian life, is what she's arguing. Let me find out where I am here. She describes it by saying, as a result, man has his own monastery in his spirit behind high white walls. There he abides in the fullness and purity of his communion with God, and from there, by some way of condescension, some sort of patronizing, he descends into the sinful and suffering world. She argues that there should not be this division between primary and secondary, that we should not just occasionally condescend to enter the world to care for the poor, homeless, hungry, and imprisoned, but that this should be the heart of our Christian lives and absolutely essential. And I want to argue that we should be taking this concept and applying it where we work with our patients and clients. And Christ is the first and perfect example of this worldly endeavor, as she calls it. In his worldly obedience, she says, he emptied himself, and his emptying is the only example for our path. She asks, when and in what moment did his example teach us about inner walls that separate us from the world? In the Eucharist, he gave all of himself, his body and his blood, without stint. Neither did Christ teach the apostles to be sparing and cautious in love. Have you guys ever felt yourself to be sparing and cautious in love? Because I have, for sure. More to protect myself and not get burnt out on the terrible tragedies that I see at work and that I see at the world at large. But also, what about burnout? I'm not Jesus, and I don't have everything in me to empty myself into the world. And this could be a whole nother seminar. But her response to this is, if our approach to the world is correct and spiritual, we will not only to have to give to it from our spiritual poverty, but we will receive infinitely more from the face of Christ that lives in it, from our communion with Christ, from the consciousness of being a part of Christ's body. So she's saying that we're not just going to go get our spiritual tank filled up at church and then go out into the world and just empty it all out and then go home empty and have nothing to give our families. She's saying we're going to go out to the world and we're going to meet Christ in the world, in the poor and the suffering. I'm going to meet the face of Christ in the girl who comes to the ER every Friday night and vomits red wine into her hair somehow. But because that person is Christ to me, that person's an icon of Christ, and I can approach my interactions with this person as a veneration, that will also fill me because that person's being Christ to me. Now, I don't know exactly how this works in practice. This sounds kind of mystical. You know, maybe God, this is not something that we can think ourselves into. But this is her response to that. She further states, he, meaning one, a person, meets Christ himself face to face in the one to whom he offers himself. And in communion with him, he communes with Christ himself. The mystery of union with man becomes the mystery of union with God. What was given away returns, for the love which is poured out never diminishes that source of that love. For the source of love in our hearts is love itself. It is Christ. So I just want you to go home and reflect on what would happen if we applied these concepts to our relationships at work. And I don't say this on a whim. I say this not because I'm like Mother Maria either. But many years ago, I approached work as, all right, I've got to provide for my family. My husband's in seminary. I'm the only person bringing in an income. And this is why I'm here. And New York was the worst state I ever worked in. It was terrible. But I began almost hating the patients I would work with. And it wouldn't be the nice people that I was hating, right? It was the disgruntled people who'd been waiting in the waiting room for 15 hours and then would bite my head off about it. And instead of responding as a Christian would respond, as Christ would respond, as St. Maria would respond, I would respond in kind. You're going to be rude to me, I will be rude to you back, right? Because that just feels good. And I would end up dreading going to work. And there was just so much anger all surrounding it. So I started praying every time I went to work that Christ would help me see all these people, including red wine vomit girl, as icons, because they are. And it wasn't like an overnight thing that changed, right? It was a slow progress. There was never a switch that flipped that suddenly I was all better and I'm not a hateful person. But praying that for multiple years, going to midwifery school and learning what I learned about health disparities has shaped me into a complete different nurse than I was 8 years ago. Glory to God. So I'm not saying this is like a formulaic thing that we can think out, but that this might need to be a work in progress. And I think maybe this is more applicable to medical professionals because psychology professionals, you guys are already kind of like warm and nice. But a lot of us medical people can be really bristly and we can be, especially when we're in a rush, we are not so warm and nice. So I just put some things up here. Let's apply it, some practical ways that we can maybe implement this in our lives. Approaching our interactions with others with this mindset of mysticism of human communion. Now, you kind of have to like read these things for yourself to like actually get it ingrained, because I am not Saint Maria and she has a way with words that I do not have. So that essay can be found in Mother Maria of Paris Essential Writings, and then her life is, her biography is Pearl of Great Price by Sir J. Hackle, Hackel. They're both amazing books and will change the way you see the people that you serve. Assess your own implicit bias, as we've talked about. Pray before work and throughout the day. I wish I remembered to pray during the day, but I just don't, so I'll pray before that God would use me as a vessel, and that my own sinful nature would be held at bay, and that I could reflect these attitudes of Saint Maria that we talked about today. Be cognizant and remain cognizant of why minorities experience health disparities at higher rates, and that it's not their fault. Sometimes you blame patients. Oh, if that patient wasn't overweight, maybe they wouldn't have had a heart attack, right? We have no idea what their lives consist of. And, I mean, what time is it? Oh, I have 3 minutes. I'm not going to share that story then. Anyway, I naturally do this myself because I'm not a great person, but I have to tell myself, don't blame them, because you don't know what is going on in their lives that led them to this point. Just love them and care for them. And then mind your speech. I don't know about you guys, but my tongue can wag. And I just don't mean your language. I mean how you're speaking about your patients to other people, other staff and whatnot. Because it is so easy to get, especially in the ER, to get into that person in that room, you know, and it's always judgmental. So these are just practical things that I came up with. I'm sure you guys could probably come up with other things as well. But
These are great. And that last one, if you have trainees, they'll call you on the mind your speech one.
yeah.
Which is really good.
Yeah. So we have 2 minutes left. Does anybody have any questions or comments?
I have a thought. There was a question that was asked earlier today during one of the plenary speaker sessions about how compassion in the secular world is distinguished from compassion as Christians.
Yeah.
And that came to mind when you were talking about burnout, because in hospital settings or in healthcare settings, when we talk about burnout, there's a limit to how to treat burnout without Christ. But it seems like, and it just occurred to me as you were speaking, it sounds like with Christ, it almost seems like the solution to burnout might be pouring yourself, maybe not into the work, but into Christ, which may be the work. And I don't mean work like my job, but maybe the vocation through the people who are the icons of God, which is different than spending 80 hours a week at work itself. So
Totally.
I mean, I don't know what that means, but that sounds like there's something there.
Yeah, for sure. And I thought about this talk whenever that came up, and I thought, I wonder, you know, obviously you could just say, yeah, the difference between us and the world and providing compassion is that we're Christians, that we have Christ, right? But what does that actually look like? And I think Saint Maria's life was really inspiring in that, because she will just continuously talk about, and she got exhausted. She got burnt out. You know, she was totally like, I'm done with this. But then she'd wake up the next day because her convictions were so strong that these people are Christ, and I cannot be holed up in a monastery just praying. I have to go out to the market and get food for them because they're still going to be hungry. And she had that conviction so strong that it helped her push through the burnout. And like, we're not all going to be able to do that. But maybe if we came from this mindset of strong conviction of these people are Christ, they're icons of Christ. I need to venerate them, even if they're dirty and stinky. Yes.
And I just want to underscore exactly what you said, because one of the extraordinary things about Mother Maria is that she challenged this temptation to keep going back to the rituals of prayer that are so embedded in Orthodox monastic life, and also in our understanding of spirituality and holiness. And it's not that she says don't pray, but she really kept challenging us to go to that self-offering in the human interaction, to find there the Christ who will fill your heart and keep you. So I think exactly what you were pointing out. I just wanted to underscore that that's like one of her most controversial things, actually. Some of her nuns left her community because
They were scandalized.
They didn't have enough time to pray, you know, and she would be late for services and sometimes miss them because she was out in the various bars looking for the people who were bereft of God and also any kind of services in great need. So I think that's an important thing to underscore.
Mm-hmm. Yeah, she was very scandalous to the other nuns in her time because she would, if a need needed to be filled, she would totally skip a church service and fill that need. And it was very, didn't sit well with a lot of people, including one of the priests that was sent to work with her at her hospitality house. She was like, I can't handle this.
Well, thank you.
Yes, thank you. Thank you. Thank you all for coming.